So we'll get started. Suzanne?
All right. Hello, everyone. So I would like to introduce you to Thekla Oechtering. She's a visiting professor at the University of Wisconsin in Madison right now. And she has actually achieved already a lot in her life, I think. She was named ISMM Junior Fellow in 2022, and she is also the recipient of the Albert Schönberg Medal, and the youngest female to get that, actually. All right, but her talk today will be about quantitative flow imaging, clinical applications, and unmet needs.
Thank you so much, Susanne, and thank you so much for the invitation to talk about quantitative.
Yeah.
Thank you so much. Can you hear me now? Yeah. I'm really happy to talk about quantitative flow imaging, clinical applications, and unmet needs. I've done 4D flow imaging since med school for 12 years now, so I love this topic, and I hope I can bring the love to this topic and to you. So I'll start with where do we stand today? What are clinical applications of quantitative flow imaging? Then I will dream with you about the clinical applications of tomorrow. And then we will discuss what mountains we need to climb to actually reach these stars of the bright future of flow imaging of tomorrow. So today, clinical questions for flow imaging can be broken down to 3 basic pathologies, the majority of clinical questions, of course. Is there a stenosis? Is there a regurgitation? And are there shunts? If so, how severe are they? And can we monitor the treatment? We do this with 2D phase contrast MRI, and we measure velocity, flow rate, stroke volume, and pressure gradients to do that. We apply these things to the heart, to large vessels, and to neuro applications. So let's start with an example of a valvular heart disease, an application, a cardiac application. So as you can see in this patient, the aortic valve isn't really moving a lot, and you can see there's a stenosis and an insufficiency jet, which indicates heart disease, valvular heart disease. But you can't tell how bad it actually is. To do that, you need quantitative flow imaging, and you need to measure the velocity. So we do that, and we get the peak velocity, which then tells us how severe the stenosis actually is, and this is a moderate stenosis with almost 4 meters per second. If we're feeling very fancy, we can even calculate the pressure gradient. Then that's the first pathology to analyze. Then what about regurgitation and shunts? For that, we don't only need the velocity, but we also need the area to calculate the flow rate. That gives us the antegrade and the retrograde flow volume, and we can calculate stroke volume and regurgitant fraction. In this patient, the regurgitant fraction is about 40%, so again, moderate insufficiency. We need the stroke volume to answer questions about shunts. And this is a case from Michael Markle with an atrial septal defect. And again, to answer the question, how bad is it, you need quantitative flow imaging, and we measure the stroke volume in the aorta and in the main pulmonary artery. And then we get the ratio QP/QRS, and in this patient, there's almost 4 times as much blood flowing through the main pulmonary artery than the aorta. So this is severe, and this patient needs treatment. So what about flow imaging of tomorrow? I think we can answer much more than these 3 basic questions. I think we will add many other pathologies, and I think we will add prognosis to our repertoire. I think we will be able to say something about the prognosis. I think we will use 4D phase contrast MRI more often, and that gives us a myriad of parameters, some already established, and lots of fancy new parameters that are exciting to explore. So where can we use that? We can use that in cardiac applications, and we'll have lots of interesting talks about this in this session. And just to give you an example, very basic, congenital heart disease, it's very tedious to do all these 2D flow measurements to actually characterize the pathologies with 2D flow imaging. But with 4D flow, as you know, we can image once, cut many, and get all the information that we need in one scan, but it takes a little bit of more post-processing. And these are only already established parameters like flow, volume, flow rates, and this is already used in clinical routine in specialized centers. I think we can go further than that and not only use the basic parameters, but also advanced parameters like energy loss and intracardiac flow components to really characterize cardiac function and other pathologies. Let's continue with large vessels. I think one very important pathology to add to our repertoire that we have right now is the prognosis and of aneurysms and dissections, where we don't need flow imaging at the moment, but I think we will need it at some point in the future. Imagine how exciting it was when we've learned that the wall shear stress that we measure with 4D flow MRI actually corresponds to aortic wall degeneration, and we can see this in histopathology, the degraded fibers, and that was exciting. But now we can get even one step further. And Michael Markle's group and the Barcelona group published results that the wall shear stress they measure with 4D flow MRI actually predicts the dilatation of the aorta in these patients. And this shines a whole new light on previous research. For example, research we did back in Lübeck with our cardiac surgeons, and we examined patients after cardiac surgery with different valves. And some valve replacements allow for near physiological flow. Others lead to very disturbed flow. And this will have an impact since the wall shear stress is deranged, and so we might need to rethink lots of our therapies that we use right now. Then again, let's talk about neuro. Also, we can do in neuro applications, we can start very basic, just with direction of flow, as we did in this subclavian steal syndrome. And we can also use 4D flow for treatment monitoring for carotid endarterectomy in this example. But again, we will go one step further, I hope, and predict the risk for aneurysm rupture, for example. There are two other pathologies that we don't have talks about in this session, but I think they're still very exciting and new and worth to talk about. So let's start with pulmonary hypertension. The Graz group found out that the vortex duration in the main pulmonary artery allows accurate quantification of the mean pulmonary artery pressure gradient, something that we usually do with invasive catheter measurements. That could help all these patients that don't need invasive diagnosis anymore. Unfortunately, other groups, including our own group, we weren't able to reproduce these results, but there are other parameters out there on top of that that could help with diagnosing pulmonary hypertension. So I think this is a very interesting field that could help a lot of patients. And then the final pathology I'd like to talk about is portal hypertension, the research focus of the Madison group. Portal hypertension is high blood pressure in the portal vein that supplies the liver. And patients with portal hypertension can develop gastroesophageal varices that are at risk for bleeding, and they can actually die from this bleeding. There is good treatment for this, but we need to detect these patients first. And the way to detect them now is invasive EGD regularly. Most patients don't like that very much. So wouldn't it be exciting if we could just lay them in the MRI scanner, do a 5-minute flow exam, and then identify the patients who actually need the invasive procedure and spare all the rest, the invasive procedure. So we're actually starting a study right now to analyze this in a larger cohort. So how do we get to this bright and exciting future? I think we have still some technical and clinical challenges before we can actually implement this in our clinical routine. One of the most important technical challenges is that we need to improve the robustness, reproducibility between sequence, vendors, and post-processing software. It would be great if we could acquire a broader velocity sensitivity and reduce the acquisition time. I think it's essential that post-processing becomes quick and easy for clinical routine, and that we break down complex data to essential information. On the other side, the clinical we have lots of people working on these technical challenges, and there are some brilliant people who present their work in this session. So, and on the other side, the clinical examples, we need to determine the relevance of 4D flow MRI parameters in pilot studies. Again, we'll hear lots about this in this session. But then on the other side, we need to go one step further and prove the relevance and the prognostic value of these parameters in large, long-term, multi-center follow-up studies. So how do we reach the stars of quantitative flow imaging of tomorrow? The most important thing is that we need to improve the robustness and the workflow of 4D flow MRI so that it's available in clinical routine. And this allows us to prove the clinical relevance. And this will actually bring us further to this bright future. And with that, I would like